NEI Spring Congress is headed to my home of Florida, May 1st through 3rd, and I hope you'll join me. Come for the latest in psychopharmacology. Stay connected with like-minded clinicians and experts. Walk away with the tools that make a real difference in clinical care. Registration is open now, and spots are filling fast. Use code NEIPOD26. That's all capitalized, NEIPOD26. Register now at nei.global/spring.
Welcome to the NEI podcast, PsychopharmaPearls, a brand new series created for busy clinicians. Hosted by Dr. Andrew Cutler, psychiatrist, psychopharmacologist, and chief medical officer of NEI. These 30-minute episodes deliver practical psychopharmacology pearls and real-world strategies you can put into practice right away to better support your patients.
Hello and welcome to another NEI podcast, and this one is in our series called PsychopharmaPearls. And with me today is a good friend and my boss, actually academically at SUNY Upstate Medical University, and a longtime NEI faculty member, Tom Schwartz. Tom, how are you?
Hey, good. But actually, right now you're my boss.
That's true.
What are we going to do from an NEI point of view? Who's in charge today?
We'll take turns, is what I would like to say.
Yeah.
So we're going to be talking about an interesting and important clinically relevant topic about managing rebound insomnia after antidepressant discontinuation. And I know, Tom, you've done a lot of work on antidepressant discontinuation. You've done work on insomnia. So you're really a perfect guy to pay attention to this.
Yeah, sure. No, it's one of those things. Insomnia in any way, shape, and form is maybe one of the number one cross-cutting symptoms we treat, right?
That's so true. If you look at the DSM, it's a symptom of practically everything in the DSM. And sleep medicine is very hot right now because there's a number of companies developing medications, for instance, around the orexin system, which is a master arousal regulator, and so on. So I think it's true. And I think a lot of times we hear insomnia and we think depression. It's like a symptom of depression. But no, it can be a symptom of other conditions, even a primary sleep disorder, but it can be a symptom of something with the medications, right? So,
yeah, no, absolutely. Yeah, a lot of our medicines create insomnia, right? So,
or if you're treating insomnia and you stop it, you get rebound.
Yeah, absolutely. And I think you see, we can certainly ruin sleep by starting a med, stopping a med. Yeah, we can create trouble wherever we go, huh?
That is true. So let's get started with our first question. Why should prescribers pay attention to rebound insomnia when they're discontinuing antidepressants? And are there certain antidepressants that are more of an issue than others with this?
Well, I think in general, we'd all agree insomnia is no fun, right? And, sometimes it's an independent risk factor for suicide. It's a good thing to treat. We know people self-medicate with all sorts of things, alcohol, other sedatives, propofol. We have celebrity. Yeah, we have celebrities, using IVs to get to sleep. And that's how scary it is. I think it's a phobia, right? The fear of not sleeping. And then you're alone and it's quiet, it's dark, and so it's hard. So I think insomnia of any kind is bad, but when you're trying to treat somebody and maybe you are removing an antidepressant or another sleeping pill, and then you make them worse, right? And that's tough because now you created insomnia and you're the bad person. So I do think it's a big deal. I think if you're removing agents really of any kind, it's a good warning to give people. It might hurt your sleep, might help your sleep. Maybe nothing will happen, but you got to let me know. And, if our visits are 4 weeks apart, 6 weeks apart, you don't have to wait 6 weeks to tell me, right, that I hurt you or I gave you insomnia. So I do think, as you said, having that open communication makes sense, and particularly with patients that came in with insomnia. They're already sensitive to it. You don't want to recreate kind of their phobia. So absolutely, open communication, have those discussions, do the informed consent thing. I think it makes sense.
Yeah, insomnia is a very common presenting complaint. It's one of the things that bothers people the most, like you said. And it's interesting. Insomnia can, of course, be a symptom of the depression, but as you said, it could also be something related to medication. starting or stopping. I mean, SSRIs, SNRIs don't improve sleep and may in fact mess up sleep architecture.
Yeah, I agree. Yeah. Yeah. So, I mean, the other part of your question, what are some antidepressants if you stop them can create problems like this? On one level, I'm going to skip the antidepressant for a second. Where's the classic rebound insomnia? It's things like the short-acting BZRAs, the Z drugs, Zolpidem, Zaloplan, triazolam, the true benzo, right? Those real short half-life GABAergic drugs. They're the ones that are most notorious. And that's why, we kind of like to wean people off those a little bit, or at least cross over to cross-tolerant med. But I like the line of questioning here for the podcast. What about other things? Yeah. So in my experience, the kind of sedating antidepressants, to me, the ones that use a bunch of antihistamine properties, I think you can see that. Mirtazapine, trazodone, methazidone, most of the tricyclics, right? I think I've seen this kind of thing maybe with some of the atypical antipsychotics, like the penes.
I was just going to say, right, quetiapine is frequently used not only as an adjunct for depression, but just for as a sleep aid, it seems.
Yeah. Yeah. And maybe, the low potency first generation antipsychotics. So, if you're in our world and you're really geeky and you memorize where all the antihistamines are, it's easy to list these things. And I joke with my residents, I'm old enough now that I got to learn them one at a time, where they have to memorize, 30 drugs all at once. But yeah, think about it. Anything with an antihistamine property, you're removing arousal. People then, the net effect is they get tired. And I do think the brain kind of looks for that every night. So I need my H1 receptors blocked. I need to feel, the brain wants to feel that sedation, let's say. But then I think the patient's mind expects to feel a wave of sedation, and I need that to fall asleep. So you've got this kind of true biological removal of arousal with net sedation, and then you have this psychological stimulus response. I feel it, I can go to sleep. But I think when we talk about rebound and these kind of drugs, I think it's two-part. There's a little bit of biology in there, but I think there's a lot of, they're expecting to feel that hit, that wave hit them.
Yeah. Well,
I think the antihistamines are probably the biggest culprits in my practice. Yeah.
And people take over-the-counter diphenhydramine. They take some of the brand name over-the-counter sleep aids. I guess Sominex and things like that have them. So,
yeah. No, absolutely. So I think the rule of thumb I would have is almost anything that provides a modicum of sedation runs this risk. And again, it's not as formal. It's not as, severe maybe as the Z drugs, but I think we do see it. Another couple families of med. I don't know if you've seen this in your practice. The gabapentinoids, like gabapentin, pregabalin, I've seen it there. Yeah. And every now and then, I think you'll see it with like the alpha-2 agonists, like clonidine even. Yeah. And so again, a loose rule of thumb is anything that creates better sleep, way of inducing fatigue and sedation, you might see this kind of rebound effect. And again, I don't know, to the audience, what's rebound effect? You thought you had insomnia before, and we make it twice as worse because you're going through withdrawal or discontinuation. So, yeah, it's hard. People don't want that to be even worse.
Yeah.
Right?
What about the antidepressants with classic withdrawal syndromes? Paroxetine comes to mind, the SNRIs. I mean, they may not be helping sleep per se, but when you stop them, you get this rebound that makes everything worse, right?
Yeah, no, I think that's another phenomenon, right? So I think you get a discontinuation syndrome, collection of things, and insomnia can be one of them. So paroxetine, Paxil, venlafaxine, desvenlafaxine, right? So Effexor and Prestige. Yeah. What do I see in practice? So a lot of times I see people get emotionally labile. It's like all their sadness came back, but it feels different than their usual depressant, right? Maybe they burst into anxiety. We see that. I think there's an emotional component to that discontinuation, like an emotional rebound, right? And they get some of the classic, the malaise, muscle aches, things of that nature. Yeah. And that's my informed consent when we're cross-tapering a drug. And I think they might get into this. It's, if you feel like you have the flu or COVID, but you don't have it, might be side effects I gave you, right? And the other one is brain zaps. Have you even met patients with paresthesias? I think those are almost pathognomonic, serotonergic discontinuation. But then you're right. We will see people are activated, right? They're anxious, they're agitated, maybe even also like an akathisia-like feel to it, and they can't sleep. Yeah. So that's part of a bigger syndrome. Yeah, absolutely. That can happen.
Well, you talked about tapering, crossing over, but let's just focus on the taper part. What kinds of taper strategies or schedules would you use to try to minimize this risk?
Yeah, the slower you go, the better. So if time is on your side, so think of a patient, you've done a good job, you put them on an SSRI or whatever, and they're cured, they're in remission. Maybe it's the first episode of depression, got them in remission for a year, and then now you can stop the drug. And so if they're doing great, I tell my patients, let's just take a few months. We're not in a hurry here. And so I take a long time. And then I think you're not rocking the boat on any level. The brain is seeing its serotonin disappear very slowly, several weeks, 2-3 months. I think if you do that, if you have that luxury, you're probably not going to run into too many issues. But what do we do usually? What you're doing is you're ratcheting down the failing drug. Maybe you cut the dose in half for a week and start the next drug half. So maybe it really is a 2 to 4 week switch. And that usually is okay, especially if the next drug is somewhat comparable. You have a SERT inhibitor, serotonin reuptake inhibitor property. Going from drug A to drug B, they have that similarity. You're probably not going to see discontinuation. You probably go a little faster.
Yeah, that's really well said. People often use half-life as a judge in steady state for how fast to taper and whatnot, but that's what's happening in the serum or the plasma, if you will. But I agree with you. The brain doesn't like you to do anything too fast. And so I've definitely noticed that too, that you want to just take your time if you can.
I think it's kind of I don't know, it's not a debate, but we could trade stories. It's fascinating where you can find SRI properties, right? So we have an atypical antipsychotic that has kind of moderate SSRI, a lumateperone. So you kind of sometimes if you're somehow switching, and you go, oh, an atypical can't do that, but they have that property.
Yeah. Okay. Quick trivia quiz, Tom. There are 2 atypical antipsychotics that have reuptake inhibitor properties. So lumateperone is one. Do you know what the other one is?
I'm gonna take a wild guess.
And it's a trick question because it's not the parent, it's the active metabolite. That's what I'll tell you.
Of lumateperone?
No, for the other one I'm talking about here.
Active metabolites. I was going to say ziprasidone has some.
That's interesting.
You might be going after, is it paliperidone?
No, it's quetiapine. Quetiapine is a potent norepinephrine reuptake inhibitor.
It's got the NRI. Yeah, right.
And that could be part of the discontinuation withdrawal syndrome.
Yeah, my head's in the serotonin clouds.
Yeah, exactly. I threw that curveball there. Yeah,
there you go.
But
it's fascinating, right? And so again, that's why we get into this geeky world of pharmacodynamics.
Exactly.
Dextromethorphan.
Oh yeah,
has serotonergic properties.
So
there's lots of drugs floating around there. It means if you took those away, maybe you'll see some of this as well.
Well, that's a really good point, Tom. We now have the dextromethorphan bupropion combination, which has a relatively short half-life because, you give it BID. I hadn't thought about that. I did some of those trials, and we didn't taper it down at the end. We did stop it when the study was over. But I wonder if in the real world, you might see it, like you said.
Yeah. And maybe it's, milder, if there's weaker SERT inhibition properties.
Right.
Yeah,
right.
But it's fascinating, the world we live in. We think about the big gun culprits. There's some zebras out there, right?
Yeah, that's well said. I agree. Now, here's an interesting question. Are there particular patient populations, say anxiety, bipolar spectrum, those who start out with intense insomnia, that are more vulnerable or that you might even approach the discontinuation differently?
Yeah, I think so. And again, my practice, my niche is a bit more in the treatment-resistant unipolar depression, MDD. But in that group, it's anybody with pre-existing, kind of the primary insomnia, right? Let's go back to that. So it's the fear of not sleeping. They're watching the clock. That gets reactivated so fast. So I do worry about them. It's the comorbid in my practice, that group with PTSD. Sleep is even, I think, hurt more by that combination. And again, I think, you're a bit terrorized by not only not sleeping, but when you sleep, you get nightmares. And if you finally get that fixed, the risk of disrupting that. So I like to work with those patients a bit more cautiously. I think you're right. The bipolar patients, insomnia can trigger their next mania event. So that's a group. Again, I don't have a big bipolar cadre in my practice.
But I don't know where you are on this spectrum, but of course the use of a traditional antidepressants is very controversial anyway in that population. Yeah. And a lot of us...
We've seen that dropping, yeah.
Yeah, it has a little bit, but still the number one most prescribed class of medicines to a patient with bipolar, even if they're diagnosed bipolar, is an SSRI. Hate to say it, but it is. And,
despite all the public service announcements and guidelines out there, you're right.
Well, we all inherit bipolar patients who are on these drugs. And so, of course, we would want to try to clean them up a little and maybe taper that off. So that's something to be aware of. The anxiety patients, in my experience, Tom, are very somatically focused. And I find with them, I have to be real careful, both starting, tapering up, titrating up, and then coming down, tapering off.
I don't know if you do this either. And for patients who are really worried about just take more time and make smaller jumps when you're cross titrating. And again, if appropriate, you might have to use a hypnotic, a sleeping pill, a PRN. You have to get somebody through. There's a variety of those out there. But for those folks who are really vulnerable, I think you have those discussions. Oftentimes you can tell people rebound is usually limited. You can put up with it. It won't go on forever. But, if you need to do something, here would be a safe PRN approach.
Well, that's interesting too, because you know what happens, right? You always get the call, Friday afternoon, I forgot to refill my venlafaxine prescription.
Yep.
And they go into withdrawal just over the weekend. So maybe having something to use PRN, should that situation occur, that's interesting. I hadn't thought of that. What's your experience, Tom, been with the DORAs, the dual orexin antagonists?
Yeah, so far so good. They're an interesting group, right? So you and I grew up roughly the same era. So I grew up with the true benzodiazepines, and we got the BZRAs, a little cleaner, a little bit better on the sleep architecture, maybe a little more parasomnias at night. But, still risky if you're mixing opioids, alcohol. You can still get into some of the overdoses, respiratory suppressions. I think with those drugs, what I ran into outside of this rebound, if they ran out, we quit it too quickly. It was pretty rampant, I think. You kind of got into, I got my 6 to 7 hours of sleep, but I woke up groggy and hungover. So do you want to be groggy and hungover from your insomnia or the meds I gave you? So I think that class of meds, even though they're shorter acting, I used to run into, I got my sleep, but there's some consequences to it.
Are you talking now about the Z drugs or the DORAs?
The Z drugs, yeah.
Yes, I agree with that.
And so the BZRAs kind of had that feeling. The true benzos, it was worse. But what I've noticed with the DORAs, I see less of that. The theory, the BZRAs, the zolpidem work through the GABA A receptors. That's kind of how alcohol works, right? Through a subreceptor. And, if we drink too much alcohol, we feel groggy and hungover. It's a short half-life drug. And the DORAs just don't do that, right? They dampen the orexin systems. I think they're fundamentally different. So far in practice, I see less of that morning hangover effect, which is good to see. So I think they work. I think people sleep, but I see a little less baggage in the morning from that.
I really agree. And what's been frustrating is that there's been problems getting them covered. So they're not maybe being used as much as they could. And it is a different animal. You have to tell people, look, it's not going to knock you out the first night like the Z drugs. People sort of expect that. They actually, there's some evidence they continue to work better with subsequent use.
Yeah.
If you will.
I just had a patient yesterday have that discussion with me. He just out of nowhere said, like the previous sleeping pills, this one just doesn't hit me. And I'm like, well, what do you mean? And, this kind of wave of sedation. He says, I guess I feel tired, but I don't see it coming. And then I go to sleep. and I think people's experience with the benzos and the BZRA type drugs is you feel it coming, right? It's hard. You have to fight to stay awake with these. So it's different. They feel and they handle differently. Yeah.
Yeah, definitely. Well, if rebound insomnia does occur, and we've talked about how to try to prevent it, but let's say it does occur, how do you decide what you're going to do? You're going to watchful waiting, as you said, it will get better. Can you use behavioral strategies, CBTI or sleep hygiene things, or would you cover with a little short-term medicine, or does it depend?
Yeah, it's all about informed consent.
Okay.
I like giving patients choices. Some patients, I don't want a second, third med.
Yeah.
I don't want to pay another copay. And so if you have time to do that, have that discussion, that makes sense. What I almost always do is I increase the dose, the drug we were moving back up temporarily. So I almost reflexively say, look, we got you to 10 milligrams. Let's go back to 15 for a couple. Maybe we went too fast. My fault. And I own it. And then it builds comfort, with the patient. And I think that goes, we'll just slow down. And again, what do we do with benzo withdrawal? What do we do with opioid withdrawal and detox as we go back up? Bring the methadone back up. We'll try again in a few weeks. So I like that if we have time, and it's not having other side effects. So just reset your titration and slow it down, make the increments smaller. But if patients are like, I think I can put up with this for a week. Okay. And then, if they can't, I think what could you do? I mean, you certainly could use a benzo, a Z drug, an antihistamine, Dora. If you're opening another can of worms, you're adding another medicine, another copay, maybe they get overly sedated. But if that's really needed, we don't want to trigger a mania. I got to get you to sleep, right? Yeah. So I think sometimes you have to do those things.
Yeah. What's always been fascinating to me is the American Academy of Sleep Medicine recommends CBTI as first line before drugs. So maybe there's a role for that here too. Or like I said, just sleep hygiene. There's so many patients who just don't practice good sleep hygiene, right?
So, yeah. And again, I can soapbox a little bit about sleep hygiene, and I'll share with you why. But, the problem with CBTI, awesome. It can work as good as any sleeping pill, but it's a 5 to 6 week protocol. So I don't know if it works in these abrupt situations, but what if a person did CBTI 8 years ago? It would be a refresher class, and maybe it is a one-hit wonder. So, if they have a CBT history, I think that actually could be very helpful. And then sleep hygiene, your friend and mine, Jade Wu.
I was just thinking of her when you said this. Yeah.
She and I have a talk coming up here at Upstate Medical in Syracuse, and we're going to do a little bit of a debate, CBT versus some of the sleeping meds. And again, she made me remove my slides on sleep hygiene. Says it really statistically doesn't work. And she says, now I know you have to say, try it. And we are all going to try it. It makes common sense. But from an effect size point of view, she's not convinced it's really helpful. But again, we of course we're going to try it. Get a routine, do good behavioral things before you go to bed,
Sure.
Don't watch a lot of horror.
No screens.
On TV,
no screens. Dark room, all that.
Yeah. So,
but
so I think we can all do that. Yeah.
I know. What's really important though? A lot of people use caffeine, especially if they're having fatigue and trouble in the day, and people metabolize caffeine very differently. And so just cutting off when you have your last caffeine drink might be helpful, because some people keep going into the afternoon.
Yeah. No, absolutely. And again, just think of the other self-medicating things. You think alcohol, we're talking about GABA activity.
Absolutely.
I think it's a terrible sleeping method. Short half-life, burns out of your system, and your GABA goes away, your glutamate spikes, and now you're awake.
And it also disrupts sleep architecture. It knocks you out, but you're getting more of the, lower stage sleeps.
So I do think good, minimize your caffeine. Let's make sure you didn't get into having that nightcap before you go to bed.
Yeah.
I think, and would I do sleep hygiene? Yeah. I think some people have very, bad sleep regimens, right? And sometimes that is the fix.
Yeah. The other thing is I'm a big fan of harm reduction. Sometimes you're not going to get total abstinence from, say, alcohol or marijuana, but if I can get them to cut back on it, I'm sure it's going to help. It just makes sense.
Yeah. And the other thing you can do with cannabis is interesting. So, in my mind, it's both an upper and a downer all in one drug, kind of a stimulant too. But I've had some good success. I think sometimes it's hard to talk folks out of their use pattern or to lower it. But where I've gained some traction is because they think I'm some unofficial cannabis weed doctor. But you start talking THC versus CBD content, right? And one idea is, hey, I don't care if you keep smoking the same amount of joints or gummies or vaping it, but when you go to the dispensary, lower your THC content, right? So CBD is a little more to protect. Maybe it'll, but I think you're going to lose some of the activating parts of weed, I think. And people look at you like, I thought you were supposed to scold me and tell me no. And I'm like, no, I want you to cut back. But the way you cut back, like coffee, you go to half calf. Could you go to half cannabis? And, you really don't need all that THC, right?
No, that's good. Well, and there is some evidence
you
that
get buy-in, right?
And there's some evidence CBD is calming, actually. So that might make sense.
So I think it's getting buy-in. You're right. Can we find a way to improve those things without being harsh and in your face? And then you're a team, right?
Mm-hmm. Yeah. Now, of course, Tom, you are famous at NEI for introducing the Most Common Mistakes I've Made series.
Yeah.
And so let's talk about a little bit. What are some of the common mistakes clinicians can make when stopping antidepressants that could make this worse or whatever?
Yeah. I think there, in some ways, there's that brutal memorization stuff, right? What are the things that can get you in trouble? And we talked about them. Stopping paroxetine, venlafaxine, desvenlafaxine. Those are the big three. Shorter half-life, aggressive serotonin reuptake blockers. So if you're using one of the big three, take your time, or just use very small jumps. If things are slow release in tablets, you can cut them, you can quarter them, sometimes in liquids. I mean, if you really have to, you could micro titrate on. But I think just know your enemy, right? Those three are the ones from an antidepressant point of view will get you in trouble. And then just slow things down, cross titrate. Then you have to memorize what are the other drugs that have SSRI potential. And if you're moving completely away from that, here's the mistake we see. If somebody's moving from one of these SSRIs and they go to bupropion. No serotonin in that one, right? Or the new one, Tapering. There's not a SSRI component. And could you run into this kind of serotonin withdrawal, which gives you the rebound insomnia stuff? So somewhere, it's tough in our world. There is a little bit of brutal memorization, right? When you leave those big three, if the next drug doesn't have some of this property, I can tell you another trap I think I've seen, vilazodone. Really nice antidepressant, real sexual problems, weight problems. It's not the most aggressive SSRI, though. And at low starting doses, especially if they take it without food, they don't absorb. You don't have a lot of cross tolerance yet. So I have seen if you switch a half-life, a short half-life, let's say paroxetine too quickly, and you haven't built that one up, I've seen a little bit of withdrawal. So again, when you get into the weeds in this, somewhere there is a little bit of kind of memorization, and then the first time you start seeing that kind of discontinuation, you never forget it, right?
That's so true.
Sometimes we learn by our mistakes. Yeah.
And of course, with vilazodone, you do have to titrate because of the risk of GI side effects if you go too fast. So that's definitely a good one. I guess a couple of things I might add, if I could, would be some of the things we talked about, maybe not inquiring about all the other medicines they're taking. I'm a big fan of that because sometimes we're not aware there's another provider in maybe another field of medicine prescribing these other things that could be part of the problem. Yeah. And we talked about drugs of abuse and over-the-counter sleep aids. Also, maybe not establishing a good baseline of what their sleep pattern is like pre-morbidly or even before we start the medicine so that you really don't know what's going on anymore. Is it, rebound? Is it pre-exist? Is it the disease coming back or something?
Yeah, maybe we need to do a better job when you meet the patient for the first time. You go through SIGI caps and you say, how's your sleep? And they say bad. You take that at face value, but sleep bad, initial insomnia, terminal insomnia, you sleep 8 hours, but you're not rested. Maybe that's because I do think you're right. As we add different meds, we can hurt sleep with the SSRIs, SNRIs. We probably improve it with the sedating antidepressants. But then you go back to it. And it wouldn't surprise me, somebody that had, initial insomnia, when you start your SSRI, comes back and now they have middle insomnia. So their depression gets better, right? And their initial insomnia is better. Now they don't sleep all night long. They're up and down with micro awakenings.
Right. Ooh, that is such a good point, Tom, to look at the pattern. Not all insomnia is the same. Look at that pattern of insomnia. That's fascinating.
Yeah. Okay. And going back to sleeping pills, I don't know if you've noticed this too. The two of the Z drugs, Zolpidem, Zaloplan, I don't think they necessarily get you 8 or 9 hours of sleep for it. And what do you do with the person with terminal? They wake up too early in the morning. You need a longer half-life drug, maybe a Zolpidem, maybe the Doras. So I do think we get into memorizing half-lives and pharmacokinetics sometimes because, you change somebody's insomnia to now they're getting up every day at 4 a.m. That's no good either.
There's also Zolpidem CR, which I don't know how often that's used. But well, Tom, we're getting to the end of our half hour here. It's gone by so fast and it's been so interesting. If we could just leave the audience with a couple, maybe top 3 clinical pearls here for preventing and managing the rebound insomnia. We've talked about a bunch of them, but what would you want to leave them with?
So I'm going to lead with your last idea. That was a good one. Know what your patient's sleep pattern is. So first day you meet them, and then when you're messing around with their medicines, come and go, you recheck in. So know your patient's typical sleep pattern. I think that's a great one. The next one would be as you're moving from drug to drug, pay attention to worsening sleep because we do this to our patients. And then be aware of those folks who are vulnerable. Previous bad insomnia flips into mania, maybe PTSD. Absolutely. So I think that's another good one. Be careful with your vulnerable populations and monitor better, have better informed consent. I don't know, and be ready to adapt. Because no matter what we tell you, you might run into some withdrawal or discontinuation and go fix it.
Yeah.
Back up, redo your titration. So just be flexible.
Absolutely. Yeah. Well, I would say, take your time is one thing I'm taking from you. The brain doesn't like you to do anything too fast. And then I really loved your point about shared decision-making and informed consent, and having that really open dialogue where the patient can feel comfortable telling you right away rather than waiting to the next visit, which might be weeks later and so on.
Yeah. Absolutely.
So Tom, thanks so much for your time. This is great. I look forward to seeing you at our next meeting, which is coming up, the Spring Congress.
All right.
And I look forward to working with you as always to educate your residents and students.
Great catching up. I hope I get a good performance work evaluation from you.
I think you're going to do all right with that. Absolutely. All right. Well, thanks everybody for listening. And of course, you can get our podcasts anywhere you get podcasts. It's called the NEI Podcast, or you can search my name. I'm indexed as the host, Cutler. And for more information about all of our educational offerings, our products, our live meetings, our virtual meetings, please go to our website, NEIglobal.com. Thanks so much. Tom, take care.
Thanks for joining us for this episode of the NEI Podcast, PsychopharmaPearls. Designed for busy clinicians, these episodes bring you focused insights you can put into practice right away to better care for your patients. Please let us know what you'd like to hear more about by leaving a review. And don't miss an episode. Subscribe today. For more trusted education, visit NEIglobal.com.